Dr. Rick Angelo has been visiting University College Cork to give grand rounds and to talk at the Tyndall National Institute conference, which is on this week. Rick, for the last 5+ years, you've been involved closely with examining how surgical skills are trained. What's the major conclusions you've come to?
Well, I think one of the most important things is that by identifying specific goals and then breaking them down into metrics and measurable events, we've seen that when the trainee has the opportunity to focus on very specific sets of skills, that their ability to reach a predetermined benchmark is dramatically higher than our traditional methods of training.
So the traditional apprenticeship model, the Hallstedian model, are you implying that there's more wrong with it simply than the reduced work hours that the trainees have to acquire their skills during the residency training program?
Well, I certainly think there is. One of the issues is that with an apprenticeship model, the experience that any one trainee gets might be quite variable in terms of their exposure to rotations, how much time they spend. So at the end of what would be a specific period of time, perhaps 4 years or a 5-year residency, some of those residents would have had significant exposure to certain types of procedures. Others might have exposure to different procedures. So the result is, number one, quite variable in terms of their experience. And number two, it's quite efficient. They may spend much more time in one particular discipline or type of surgery, and they may have learned as much as they're going to learn and still be spending time in an apprenticeship model. So it's not very efficient.
And many surgeons would argue that it's not really possible to measure what a surgeon does. It's not really possible to measure intraoperative surgical performance. Do you accept that?
No, our experience over the past 5 years with the research that we've been doing is that you can, it's a great deal of work, but you can break skill sets down in particular procedures, for example, into discrete steps and perhaps more importantly errors and sentinel or more serious errors. And so the critical issue is that those steps need to be accurately defined. And I think this sort of leads us into how do you measure those skills. And a crucial element is that in the past we've tried to measure skills using a global or a Likert type skill assessment tool, which is basically taking subjective evaluations, assigning a number to them so that we can manipulate those statistically. And what happens is that with the subjective assessments, it's very, very difficult to get consistent, reliable scoring. And what we've learned is that if you clearly define the task to be learned with beginning and end points, then a reviewer can simply assess whether or not that step or error occurred or did not occur. So it's very binary. And so the Interrater reliability that we were able to achieve was quite high, over 90%. But it basically goes back to being able to discretely define each of those metrics.
Just explain to me, what's Interrater reliability and why is it important?
Well, interrelated reliability relates to the ability of assessors, if that's a pair or a group, for example, to be able to observe a particular event and have an agreement on that event as to whether it did or did not occur high enough so that it's reliable. So for example, 80% might be a commonly accepted minimum standard for agreement. So if you and I are evaluating a particular trainee and we can't get past 50% agreement, then our assessment isn't of much value because we don't know which one is right half the time. But if the Interrater Reliability, you and I, rating the same event, can be greater than 80% accurate, then we can say this can stand up to scrutiny and it's reliable in the sense that it's accurate feedback and accurate assessment.
So over the past number of years you've been identifying the metrics, the steps of the procedure, the errors or the deviations from optimal performance, and you can reliably assess those. So what do you do with those then? I mean, do you just use them for training in the clinical situation, or do you use a simulation, or do you use an animal model? And is one superior to the other?
Well, the first issue is what we do with it. I think what we learned is that intuitively we might say if you had an accurate assessment, we might be able to identify those trainees who really are struggling and maybe are just not going to be able to master that particular set of skills. But what we've learned is that the tremendous benefit is that it takes the entire group of trainees and raises their performance level substantially higher, so that while yes, we will perhaps identify some outliers that are struggling below, the tremendous benefit that we saw in terms of the research we did was that the groups that followed the proficiency-based progression pathway, harnessing simulation, were tremendously more likely to achieve the benchmark that was established for that particular procedure.
And could you just explain to me what's proficiency-based progression?
So proficiency-based progression dictates that a trainee has to master and demonstrate the mastery of certain skill sets before they can progress on to the next level of skills, which are increasingly more complex, so that by the time they proceed through this process, they have demonstrated the acquisition of skill sets that the group of which make up the entire procedure. So it's not simply hoping that they can achieve the benchmark. They've met those standards all the way along the way. So they've demonstrated proficiency, and that determines progression.
So traditionally we assume and infer that somebody has acquired certain skills and they progress, you know, to increasingly more complex procedures as training stands today. But the approach that you've been looking at doesn't make that assumption. That requires the trainee to demonstrate that they've reached a certain benchmark before they progress. Is that a reasonable way of putting it?
It is, and I think that it may be in some respects overstating it, but perhaps an analogy that exists is that when we train surgeons today, we have that group perform exceedingly well at ground school, and then we take those individuals who've done well at ground school, and the next day they're in the co-pilot seat, and the pilot says halfway across the flight, "Okay, Tony, you take it for 10 minutes." And then you progress on with that, and you fly for longer periods of time, and so the efficiency and the effectiveness is very broad. There's a certain level of risk that something might occur that you're not prepared to handle because you haven't seen it enough before. And so it's not a very efficient, and it's not the safest way to train individuals, particularly as the challenge and the complexity of surgical procedures increases. It's a very difficult way to reliably ensure that the training is adequate.
Can we just continue on with the aviation example that you used? Now, the aviation has probably the best simulators available for training high skills. A lot of the surgical community tell me that the simulations that they have available for training their skills are nothing like as good as the simulations in the aviation environment. What's your experience about simulation fidelity and training effectiveness?
Well, so fidelity, I think, is an issue that's perhaps in some respects misunderstood. The natural inclination is to think that we must have the highest fidelity simulator for it to be very effective, but that's not true. The simulator needs to mimic the task at hand, and so the task itself must be defined first, and then you determine what fidelity of simulator is necessary to mimic that task. So for example, arthroscopic surgery, there's a great deal of knot tying. And so an example would be an arthroscopic knot tying board, which probably costs $25, enables you to accurately practice tying arthroscopic knots down a cannula with your view obstructed and only the ability to see the image on a screen monitor. It wouldn't make any sense to have an ultra-high fidelity simulator for the trainee to learn how to tie arthroscopic knots. So I think that's a critical issue, is that we need to define what it is that are the component elements that need to be taught, and then what fidelity simulator meets those needs.
And what do you think the surgical community's understanding of those fidelity requirements for using simulation to train effective and efficient skills is at the minute? I mean, does surgery have a good understanding of this?
I don't think we really do, because we have operated with the apprenticeship model for so long that we have a tendency to think that simulation is gaming and video games that perhaps our kids play quite a bit. And I think the issue is simulation in a broader sense is simply mimicking a task or skill that we need. An example would be that if you look at the learning curve, we know very well that surgeons who have a higher case volume and greater experience have better outcomes, they have shorter operative times, they have fewer errors, etc. And so the opportunity to move up the learning curve without morbidity to patients is going to be crucial going forward. We have trainees with less time to spend in the OR, they have less firsthand experience, and they're going to be going out into practice and having to gain more and more experience by operating on patients, because their training perhaps isn't as broad as it could be. Whereas simulation will provide the opportunity to create a huge fill in the gap between that trainee's knowledge.
So what's your experience from using simulation and other lower fidelity type simulations or technologies to enhance learning?
I think they can be tremendously effective if they can mimic the experience that needs to be gained, knot tying, suturing, whatever, then they are effective at moving up the learning curve. Electronic learning methods, online, all of those offer the opportunity to acquire the requisite skills without consequences. And so we talk about inconsequential mistakes. And it's not the intent to find a trainee that doesn't make any mistakes and that does everything right. The intent is to afford the trainee the opportunity to make those mistakes, get feedback, make appropriate corrections, and then be able to move up that learning curve without any significant downside to it.
You started out in this process about 5 odd years ago. Knowing what you know now, what advice would you give somebody who was like you 5 years ago and starting out in the process of understanding, building, using simulation to enhance learning. What advice would you give them?
Well, honestly, I think far and away number 1, 2, and 3 would be to get help and assistance from a mentor, an advisor, someone such as yourself, because I think that we would have made tremendous mistakes had we not had somebody who understood the language, who understood the principles involved. We would have been using Likert scales, we would have been wandering down some dead ends. So this is a new area for surgeons. Many people, as you discuss these topics, scratch their head because it's not something that we've seen before. And so these are challenging concepts, and I think guidance is critical in terms of trying to do the proper steps in a reasonable fashion and then have an opportunity to get the results that you expect.
So you have finished the study, you have published the results in the August and September and October issues of Arthroscopy. Could you just summarize what you found?
Well, so we first came on the issue of, the question we asked at the outset was, is there a better way to train surgeons? And we became familiar and aware of the issues and the concept of proficiency-based training. We felt that if we were going to go to our organization and talk about changing our teaching methods, our teaching paradigm, that we had to have some proof that it was better. And we realized that we needed several tools to do that. One was a metric tool, so that we could accurately assess a particular resident or trainee's performance. We needed a training tool so that we could help them acquire the skills, and then we needed an assessment tool so that we could judge whether or not they were meeting a predetermined benchmark. So over the years, different studies were undertaken to validate each of those tools. Once we had those tools, then we said, okay, now we can do the formal assessment. So we broke up a group of residents in randomized fashion into 3 groups. The first group was trained traditionally. They were exposed to lectures, knot tying practice with a coach and a faculty member. And then once they had completed as much of that training as they wanted, they went on and studied with the use of a cadaver. The second group had similar lectures, knot tying practice, but they also had the opportunity to work with a dry shoulder model simulator. They could perform all of the steps of an arthroscopic Bankart repair, and they got, again, the opportunity to practice that as much as they wanted. The third group then was the proficiency group, and they had to actually demonstrate skills all the way along the way. So they had to pass a cognitive exam on the information that was provided in an orientation video, steps and errors, all of which were either shown or identified. They then had to pass proficiency on arthroscopic knot tying. We had a standard of 15 pounds for 15 seconds, and their loop could not elongate 3 millimeters. 3 millimeters or more was a failure. 3 of 5 knots had to pass that standard. And if they passed proficiency with knot tying, then they had the opportunity to go on and practice, study, just as Group B or the second group did with the simulator. But then once they felt they were proficient, they had to demonstrate that they could meet that benchmark for the model before they could move on to the cadaver. And so those were scored in real time. And so each step of the way, the resident had to pass a set of proficiencies. And then each of the groups had the same opportunity to work with the cadaver as long as they wanted, as much as they wanted. At the end, then each resident, 44 residents separated into 3 groups, then did an arthroscopic Bankart repair by themselves with someone just assisting them with instruments. And the entire procedure was videotaped from start to finish. And then those videotapes were scored in blinded fashion by 10 highly trained raters to assess their score, and the Interrater reliability of that blinded assessment was over 90%. And what we found out was that if you compare the traditionally trained group as the standard, those who had the opportunity to work with the dry shoulder model were about 1.4 times as likely to achieve the benchmark. The group that went through proficiency training, even if they didn't meet every benchmark, even if they didn't meet every one of the levels of proficiency, that group was over 5 times more likely to achieve the final benchmark. And in the subset, which was 3/4 of the group that went through proficiency-based training, they were over 7 times more likely to achieve the final benchmark than the traditionally trained group.
Were you surprised at the magnitude of the differences that you found between proficiency-based progression training on a simulator and the traditionally trained group?
Well, absolutely. I thought that if we could show even a 50% improvement, and if there was a group that was even 1.5 or 2 times more likely to achieve a benchmark, I thought that would be absolutely huge. But for the entire pathway of training of proficiency-based progression plus simulation to be 5 to 7 times more likely was really staggering for us.
If I could just play devil's advocate for a minute, I mean, people outside surgery or even outside image-guided surgery might say, well, that only really applies to surgery. Do you think that's the case?
I think it probably applies to just about any skill set that you are able to define. I think it's probably more likely that we see it and it's more obvious in procedural skill sets, but I think the same thing can be done if it's learning to how to transfer information on a critical patient from you to the next shift of caregivers. So I think the principles are valid and can be applied in both arenas. We tend to, as surgeons, look more at the procedural realm, but I don't think it's restricted to that.
So the study that you've conducted is probably the best, or almost certainly is the best, in the medical literature at the minute on simulation-based and technology-enhanced learning. What lessons has the Arthroscopic Association of North America learned from the last few years of doing this study, and what are you doing with it?
Well, I think that the group of my associates in the Arthroscopic Association are completely convinced that this is real and valid, and so we are in the process now of formulating the metrics for 3 additional procedures. We've completed the Bankart repair for this index study, and now we're working toward the set of metrics for an anterior cruciate ligament reconstruction, a rotator cuff repair, as well as a hip labral repair, all performed arthroscopically. So I think people are very convinced of the validity.
And what would you say have been the major issues, or will be the major issues going forward about implementing a proficiency-based progression approach to training even for procedural skills in surgery?
Well, I suppose the biggest challenge is the investment of time, effort, and energy. I think the costs involved are really because we were able to do some different things. We could keep the hard costs down, so perhaps they were less than $500,000, which is relatively small compared to many studies. But if we stopped at a certain point, but fairly far through the process, we had in excess of 2,000 volunteer hours to develop the metrics, to educate and train the reviewers, to then score videos, etc. So there's a great deal of work involved. That process will get smoother, easier, and less time consuming, but the creation of the metrics and the development of the curriculum will still take a substantial amount of sweat equity.
And would you say that your study it completely validates simulation, or is there more work to do?
I think it really, in terms of proof of concept, I don't know what else could be done. The study that needs to be done is an outcome study where you have these different groups with different training pathways, and then you follow their patients out 2 years, 3 years to truly assess their patient outcomes, and that perhaps is the holy grail of proving proficiency-based progression training and its effectiveness. But I think that there's no question that simulation and the ability to supplement learning is absolutely crucial. I mean, if we imagined that commercial airline pilots went from ground school to the co-pilot seat, I suspect that we would have a number of more headlines in the paper about catastrophic events because of unforeseen issues that came up. So,
I think it's commendable that the AANA leadership has embraced this new approach to training. And what do you think it's going to take to convince the rest of the surgical and medical leadership to adopt a similar approach?
Well, I suppose it'll be a tipping point, and what brings that tipping point about, I'm not sure. Part of it may be when the public gets an understanding of safer means of actually having their care. And in fact, earlier today I had mentioned that any of us, if we had the opportunity to have our pilot trained the way we train surgeons or the way they're trained, most of us would have the pilot continue to be trained the way they are. And so that may be part of it. I think that the medical community, as it becomes more common knowledge and they have a greater understanding of what the issues are surrounding simulation, and more importantly perhaps metric characterizations plus simulation, I think they will embrace it, and I suppose it's getting information like this study out there so that it can be peer-reviewed and examined and scrutinized, and an awareness will grow.
Just a final question. I mean, you were president-elect and then president when you were handed this ball, and you carried it all the way through, and now it's published. I mean, what are the enduring lessons or wisdoms that you'll take away from doing the study, apart from the work?
Well, I mean, I've been incredibly blessed to be involved with an organization like the Arthroscopy Association, an incredibly collegial group of colleagues and physicians, very willing to devote their time, to volunteer their efforts. I asked a lot of many people, and I think as long as people see that you're believing in it, you're investing your time in it, they're willing to come along. And maybe in another organization it wouldn't have been so easy to accomplish something that required such a demand of its membership, but I'm proud and honored to say that I think the organization was the fertile ground that made something of this magnitude possible.
Dr. Angelo, thank you very much for sharing your wisdom with us.
My pleasure, Tony.